Just a word of appreciation to all of you who are able to join. My name is Godwin Mongi. I'm an ECD specialist from Tanzania Early Childhood Development Network. I'm seconded to the Ministry of Community Development that is responsible for child development, and my role is to work with the different government ministries and non-state actors to support coordination of the national multi-sectoral ECD program. And today we have organized this webinar as part of exploring an international level, national level, different landscapes concerning issues of nutrition and how that impacts ECD, early childhood development. And we're looking forward to a fruitful discussion today. We have our panelists, Dr. Esther and Dr. August, who will be guiding us with the presentations today. And feel free, please, to introduce yourself in the chat. So everything will be recorded, and we're going to have all your information. For even with the interest, with those with interest, you can also do a follow-up. So the attendees today will not be visible, will not have the videos on. And if you have any question or comment, please share in the Q&A in the chat. And please feel free to vote. If you find any interesting questions someone else has asked, please vote for it. So those questions with higher number of votes, we'll definitely do our best to make sure we get to answer them first. Our panelists will attend to that. And of course, our webinar will be recorded, and we can definitely follow up for more information. So I will now welcome Dr. Esther to introduce herself. And while we also Dr. August we are asking Dr. August to get ready for a follow-up introduction after Dr. Esther. Dr. Esther, please, welcome.
Yeah, that's 1 minute.
Before sharing the screen, Dr. Esther, just introduce yourself first, and then we'll come to,
Yeah. So thank you so much, Godwin. My name is Dr. Ester Elisaria, a Chief Research Scientist from Ifakara Health Institute. So I'm going to present on behalf of my two colleagues, Dr. August Joachim, and also Dr. Esther Mkuba. They're also part of the team. So just a word of appreciation to my team, August and Esther Mkuba. Thank you very much for the support and for working hard on this. Yeah, thanks. And welcome all to have this wonderful presentation together and just share the experiences.
okay.
Yeah.
Thank you. So thank you, Dr. Esther. Is Dr. August able to join us today, or you'll continue on the behalf of Dr. August? Okay, so Dr. Esther, would you care to take us through the presentation? And we'll take it from there. And please remember, there'll be a useful link.
Yeah, so Godwin, are you lost or something happened? No? Oh, you're there. So should I start?
Yes, please go ahead.
Yeah, so thank you so much for attending this webinar. I'm going to take you through 30 years of stunting in Tanzania. So this is basically the analysis of the data from Tanzania for 30 years to show the trend of stunting in Tanzania and the related determinants, and also policy analysis to understand how our policies have reflected the issues around nutrition. So that is the overview part of this assignment. So why are we thinking about the stunting? I think we all know that stunting is a critical public health issue, with around 149 million children globally being affected. And in Africa, and around 28 countries are having challenges with the stunting, with nearly 30% of their children being stunted, and a much higher prevalence in Eastern and Southern Africa. And with the trend we are having now, it seems like many countries are not going to reach the global target. So Tanzania, like other countries, are also burdened with the stunting, with 30% of our children being stunted. But that has been a reduction from 50% in 1992 to 30% in 2022. But also underweight has been reduced from 25% to 12%, and wasting has been reduced from 8% to 3.3%. So for the Swahili speakers, stunting meaning udumavu, wasting meaning ukondefu, and underweight means uzito pungufu. So I just wanted to make sure that we understand those terms. So this reduction has been definitely from the contribution of the government. So Tanzania launched the first policy in 1992. So the food and nutrition policy was launched in 1992 when the first demographic and health survey was conducted. And in 2016, Tanzania launched the multi-sectoral nutrition action plan which coordinate all the stakeholders. So it's a multi-sectoral approach to the nutrition. So that was launched first in 2016. So not only that, the stunting is a global burden, and that affects many countries, including our economic aspect is also affected, but it has a direct bearing or direct impact into the child growth and development. If you look into this slide, you'll see that there are two brain that has been taken, a brain that has been scanned. So if you look into the two brains, so the first brain on our left is much bigger, and it also has a much more brain mass. But look at the other one that is on your right, the smaller brain. That is for a stunted child. So they both have 3 years, but one has a bigger brain size plus a bigger brain mass. But a stunted child has a much smaller brain size plus also the smaller brain mass. And this tells a lot in terms of the child development capacity and also their IQ level. So that is why we are talking of the stunting. That is a critical issue, and the development of a nation also need to really consider stunting as an issue. So for this assignment, we had 4 research questions. The one question was how nutrition issues has been integrated into the policies, guidelines, and strategies. So that was the first question. The second question was to establish the trend of stunting for 30 years. So this involved analyzing data from 1992 to 2022. So these were the data from the demographic and health surveys that are normally conducted after every 5 years from the government. And we also wanted to know some of these factors that are related to stunting and their trends, and also looking into how these risk factors has been either addressed or mitigated within the existing regulatory frameworks. So those were the 4 objectives. And our assignment began around May 2025 by reviewing the literature on the determinants of the stunting. And we also reviewed the policies, 20 policies plus 13 guidelines. And we pulled the data from the permission of Macro International. We pulled the data from 1992 to 2022. And that data had around 42,000 children from 7 waves of demographic and health survey. So from there also we had also some key recommendations and also the next steps on what we are going to do. So this was just a summary of how we managed to carry out all this. So now I'm going to move into a bit of the background, but also moving also into the stunting. If you look into this map, so this was the map that was extracted from the Demographic and Health Survey 2022. You will see that there are some regions with a deep red color showing that the stunting is high, like Iringa, where the stunting is 57%, Njombe 50%, Ruvuma 50%. So when you look into these regions, I think many have heard about it, that most of these regions are high food producing areas, but they're also having a very high level of stunting. So the issue is we have been looking also into the issue of service provision. If you look into the issue of service provision, there is no actually much differences in terms of how these services are provided by the government. So we're looking in whether history has also something to explain about these variations of stunting, and just wanting us to see the pattern or the trends over time. And from there, then we can think loud on what are the things that we can carry forward and implement for the coming years. So looking into the analysis for 20 years, from 1992 to 2022, you will see that, of course, the stunting has declined up to 30% now from 50% in 1992. But if you look into the average for African, it's 30%. Global average is 22. And our national multi-sectoral plan says that Tanzania aimed to reduce stunting up to 24% by 2026 for us to be able to reach the global targets. But you will see that, as I mentioned, we still have a very high stunting rate, which is 30%, but also having some regions like Njombe, Iringa, Rukwa, and others having almost 50% plus stunting, and also having other regions like Pwani and Dar es Salaam and Zanzibar, where the stunting is less than is 20% or less. So you see that even though we are making trend, there is a huge disparities in terms of the regional variations. So the other aspect that we looked when we did the analysis is looking into how this stunting vary between boys' children and girls' children. So if you look into the red line, these are boys, and if you look into the green line, are girls. So you will see that boys has been persistently having higher prevalence of stunting for 30 years as compared to girls. So when you looked into this percentage point, it's around 4 to 7 percentage differences. And looking into the existing literature, it shows that girls have always had 16% from other literature, 16% lower chance of being stunted. And this has been like a part of the global trends, which calls for more action around reduction of stunting among boys' children. But when you looked into the studies from Tanzania, like what could explain these differences, one of the study from Gairo district, it shows that this variation could be explained by the favoritism toward daughters. So there's a favor sometimes toward daughters. But other thing that could explain that is that boys' children are perceived as hungrier when they are younger more than girls, which actually make them to be introduced to early weaning. So they're given food much earlier than the girls. So the breastfeeding actually stops before it goes to 6 months. And that actually predisposes them to stunting. The other thing that could explain is that girls also spend more time with their mothers, especially the kitchen. That also increases that they are benefiting more than girls. But other studies also suggest that boys are more prone to infections, but also morbidity when they are younger than girls. And they're also saying that even though they might be of the same age, their requirement for calories is different, but most of our guidelines are still emphasizing the same amount of portion for boys and girls, but boys, the study shows that they need more calories than girls. So looking into the age trend, like how the age looks like. So if you look into this age trend, you realize that if you look into the 6 month, stunting is still starting. So it's there a little bit because some children are born with low birth weight. So they're already stunting from the birth. But it actually increases very sharp from 6 months going up to 2 years, like when you're going to 24 months. So the stunting peaks there and then starts to go down. So this tells more that it has to do with our complementary feeding, our weaning behavior. So when the child reaches 6 months, the time we start introducing family foods, the quality of our family foods is not enough to meet the nutrient content of children. So studies have suggested that most of our children are exposed to high quality carbohydrate foods, maize-based food, but also they are more prone to poor hygiene environment, especially during crawling time, where they are getting more diseases like diarrhea and intestinal worms. So this also affects their growth for the first 5 years. So looking into the low birth weight, so low birth weight is children being born below 2.5 kilograms. So if you look into the children who are born below 2.5 kilograms and those who are born with 3.5 kilograms, you realize that children who are born with low birth weight, they have much higher prevalence of stunting than those who are born with the weight greater than 2.5 kilograms. And this has been related to low birth weight children experiencing more infections like respiratory infections, having reduced immune, metabolic dysfunction, and risk of infections. But one study that was published by Ramadan in Tongwa showed that actually the higher prevalence of low birth weight is happening for young mothers who are 18 to 24 years. And this actually reflects the poor maternal nutrition status during pregnancy, and also the immaturity of the children, the biological immaturity of young mothers. So those are some issues related to the child. So we also looked into the maternal factors that could also contribute to the child stunting. So we also looked into the ANC visit, the antenatal visit. So use of ANC visit during pregnancy. So our guideline recommends that pregnant mothers should visit ANC at least 8 times. But for us, we looked at least those who visit four times. So we realized that mothers who visit at least 4 ANC visits, they have much less children who are more prevalent to stunting than those mothers who are not visiting antenatal clinic. And from the data or from the other studies, they're actually showing that mothers who are visiting health facility are benefiting from the services like supplementation during pregnancy, health education, education on weight and physical activity, and on all and the other aspect. And this has been also published by other members. If you look into the last dot, several other authors have also shown that there is a very good relation between ANC visit and actually stunting. So this is not the first time, but other studies have also found that. We also looked on the maternal breastfeeding behaviors, but this brought us to a little bit of the puzzling findings. We realized that children who are actually breastfed for a longer time, for more than 1 year, they were more likely to be stunted. And those who are breastfed for a little bit shorter for 1 year, they have a less prevalence of stunting. So if you look into these two lines, you realize that. But when you looked into more into the regression analysis, the effect was not very strong. But also what we have realized from the literature is that mothers who prolong breastfeeding, they sometimes tend to replace complementary feeding with breast milk. So meaning that they don't provide adequate complementary food to the children, so they give them more breast milk and less of food. And you all know that when the child reaches 6 months, breast milk is not enough to sustain nutrient of the child. So replacing complementary feeding with breast milk can also predispose children to stunting. So we also looked into the maternal education, looking into how maternal education is related with the stunting, and you'll see that mothers who have secondary education, so this line with starting from 36 going down to 20, these are mothers with secondary education, they have a much lower prevalence of stunting among their children compared to those who have no education or those who have only primary school. And this is, but of course, overall trend shows that the stunting decline in all levels of education, whether you don't have education or you have, because of other efforts. But when they have education, the reduction is much bigger, and they have less percentages of children with the stunting. And this actually has been argued by SEMBA, saying that caregivers who are educated are more likely to provide their children with the full immunization, with supplementation like vitamin A. So they go to the clinic for vitamin A, but they also have more knowledge on the nutrition. So this could be also the factor that contributes. And the other aspect on the maternal that we looked into is the maternal nutritional status. So these are the BMIs of the mother. And the trend shows that mothers who are overweight or that has a slightly more weight, their children, they have also a less proportion of children who are stunted. So you see from this trend that is kind of like green bluish, that they are in the much lower level of having children who are stunted than the underweight mothers or mothers with normal weight. This does not mean that we are promoting the overweight, but we are just trying to show that there is that kind of a relationship between the stunting and maternal weight. And this has been actually in line with the literature that has been coming from other publications, from what I've shown from Ramadan, from Das, from Ismail, from other members. So we also looked into the household factors for 30 years to see what is happening in the household. And we looked into the socioeconomic status of the household. And we realized that the families that has the highest socioeconomic status and also higher socioeconomic status has a lower proportion of children who are stunted than women than families with the poor socioeconomic status. And you see even that with this line, that the deeper yellow kind of color, where you see only 13% stunting by 2022, while those who are coming from poor household have 39 prevalence of stunting. So the literature suggests that families that have higher socioeconomic status are normally the families that can also access good nutrition food, but they can also have improved sanitary services, which are also linked to the nutrition status of children. We also looked into the hygiene environment, like looking into the water, but also to the toilets. So this line, the first one, shows that whether they have improved the water or not. So the families that has improved the water, so the green line, you will see that they also have a slightly lower prevalence of children with the stunting as compared to those who are having an improved water. The same applies even to those who have open defecation or an improved toilets. They have higher prevalence of stunting than those who have improved toilets. And this has also been published by Mosha, showing that actually availability of water and inadequate toilet facilities could either could also impact the child nutrition status due to the increased vulnerability to infections. We also looked into the disparities based on the regions, and you will see very clearly that regions such as Dar es Salaam, Pwani, and Kilimanjaro are faring much better than the regions that are in the southern highlands. And even when we did the regression analysis, we could also see these variations. And when we try to look critical, like what really makes these regions to be to have more prevalence of stunting, several things came up. So there's a study that I did in 2022 and showed that some of the things that actually contributed to high stunting level, especially in Njombe and Iringa, was higher female workload that limit the time for food preparation, inadequate support, male support, low women decision power over food that are protein related, like animal foods, like slaughtering chicken was not allowed for a woman until they seek permission. Also alcoholism behaviors, domestic violence, and poor wash behaviors. But we also observed that in the regions where the cash crops are also food crops, there is a tendency of selling more of the food crops, and they are left with very little or nothing at the household level. So we did also a multivariate analysis to see whether these factors we saw from the trend analysis, whether they are also appearing to really be determinants of stunting. So we realized that from the multivariate analysis, if a children is born in Southern Western Highland, they are 1.4 more likely to be stunted than those who are born in other places. And the children who are born in Southern Highland, like in Iringa and Njombe and other places, they are nearly 2 times more likely to be stunted as compared to the children who are born in other places. Also, male children have 1.5 more chance of being stunted, and low birth weight had nearly 4 likelihood of being stunted. But birth interval also, if a mother give birth when a child is 24 months up to 47 months, the risk of stunting is reduced, meaning that here we are emphasizing the child spacing. So when you give birth too close, then the stunting is increasing. But if there is a space when you give birth up to 2 years and above, then the stunting level is reduced. Also, maternal education, if a mother is having a secondary education, then the risk of stunting is also low, so 0.7 risk lower. And also the maternal exposure to alcohol increases the risk, 1.6 risk, and improved sanitary services, also 1.3 risk. And higher socioeconomic status reduce the risk of being stunted. So you will see that most of the factors that we analyzed using the trend analysis, most of them are also appearing to be the key determinants of stunting in Tanzania. So I don't know whether my colleague is already here or I should proceed with the policies. Godwin, please guide me on this.
Kindly proceed.
Okay, thank you so much. So along the analysis of the trend analysis of our data, we also did the policy analysis. So we pulled all the data from the time when the first demographic and health survey was conducted. So you realize that also in Tanzania, 1992, that is when the first food and nutrition policy was launched. And we had also several policies. We had child development policy in 1996. We have water policy in 2002. We have national population policy. We have national biotechnology policy. So we have several policies, national health policy in 2003, agricultural policy in 2008, agricultural another policy in 2013. We also had several guidelines, national population guidelines, infant and child guidelines, the guideline for management of acute malnutrition, national multi-sectoral guideline that was launched in 2016, and another one in 2021-26. We have agricultural sector development guideline and several others. So this is just a nutshell of few policies that we managed to extract for review. So what we realized from the policy analysis is that actually Tanzania has various policies and legal frameworks that support nutrition activities, and if they are properly implemented, they can continue impacting the stunting and helping to reduce the stunting. We also noted that from all these policies, there is a good emphasis on nutrition for all age groups. We also noted that there has been more attention around stunting. So stunting, wasting food security, and exclusive breastfeeding has been persistently mentioned by different documents. And around 2016, now the multi-sectoral approach came in, and that has been a recent strategy, but it's also a very useful strategy to reduce stunting or malnutrition overall. And also we have several child intervention and few maternal and community intervention that were also mentioned in different documents. But what we observed as a gap during policy analysis, you realize that our first nutrition policy was launched in 1992, and until now we are using the same policy. So there has been so many changes, so many evidence around nutrition that came out, but we are still using the very, very old nutrition policy. But also when we reviewed the issues around food fortification, food biofortification, economic empowerment, gender needs, and the context-specific and cultural factors are not very well addressed in our current policies. The other issue that was also a gap was that issues around adolescent girls, caring for caregivers, especially women caregivers, and the people with disabilities was not properly mentioned or covered in our policies. And it was until 2016 when the multi-sectoral approach came up clearly. So there has been, we'll say there is a delay in adopting the multi-sectoral approach, because we all know nutrition requires multi-sectoral approach for implementation. But it's until 2016 when this came clearly into the action. And we also have limited coverage of other components. So when we are addressing nutrition, we can't address nutrition all alone. We have to address nutrition, or a child needs holistically. So meaning that we have to address things like the health of the child, the responsive caregiving, the early learning, the safety and the security of the child. Because even when you promote nutrition, let's say you have a child who is abused and you are promoting nutrition, it's very unlikely that child will be growing normally. So meaning that if we want to address nutrition, other key components need to be reflected. The other thing is that our policies are not evaluated. So even when we did the analysis, we really wanted to see whether there is a statement or somewhere where we can say policy X or guideline X has impacted ABCD child outcomes. But we don't have those statements, or we don't have evaluation of the policy linking into the child development outcomes. Also, there has been less prioritization of things like WASH, fortification and biofortification. I think I've mentioned there already. And the guideline has also not covered issues around the maternal socioeconomic status, education, and the gender roles. So what we are bringing in as a recommendations, one, we need to have our policies updated to make sure that they reflect the latest evidence. The second part is that I've mentioned that we have overlooked some of the key groups, like the disability people, the adolescent boys, the adolescent girls, and all that. So the caregivers. So all these people and those with a disability need to be reflected into our policies. And the other issue is also we have to reflect all the 5 components of nurturing care. So issue of early learning, responsive caregiving, safety and security, and the health of the child, including also the nutrition component, need to be also included as a package. The other thing is that our evaluation mechanisms need to be strengthened. So our policies need to be evaluated to make sure that we can also relate the policy against the impact, the child growth impact. And we also emphasize that we need to have high potential programs that might affect the child development, things like WASH, improvement of WASH behaviors, also fortification and biofortification, and also sustaining and emphasizing the multi-sectoral collaboration. As we have started, we have to move on with that, and also consider context-specific factors, because also stunting is not affecting all the regions equally. And lastly, is just to say that Tanzania has made a very good progress in terms of reducing stunting, but more effort is needed. We'll also need to consider issues like budget, the lack of attention of vulnerable groups, insufficient coordination, outdated policies. All these need to be addressed if we want to move the stunting agenda forward. And thank you so much for listening. And now I can welcome you for the discussion, and later we can have also time to scan the barcode and have some session, some issues to some feedback you can give to us. So thank you so much for your participation and valuable time, and back to you all for the discussion. Thank you.
Thank you so much, Dr. Esther. And we thank you all for joining us again. We have more and more people coming in. That being said, I'd just like to remind you to continue to post your questions on the Q&A, and let us vote for those questions, and we'll continue to answer them as much as possible as the time allows. But also building on what we have just heard from this presentation, let me take this opportunity to introduce a couple of things. First of all, it is for such reasons, among others, that Tanzania, the government of Tanzania, has, in collaboration with different stakeholders, and especially the non-state actors, higher learning institutions and so forth, we were able to develop and launch the national plan of the National Sectoral Early Childhood Development Program to be able to address and put into practice just such issues. And basically realizing the nurturing care framework to influence and bring positive impact on the ECD landscape in Tanzania. And it's through that government-led initiatives and with support from Tanzania ECD Network, TICDEN, which is a network of organizations, non-asset actors, working in the field of ECD with members across all over Tanzania, and been continuing to build the capacity of these partners and asset actors, NGOs within Tanzania and international NGOs, and working collaboratively with other non-state actors also to be able to really scale, to disseminate the program and scale the implementation and at the grassroots. And we're trying to see, we've started to see the impact of this positive impact of the program implementation as being one of the fastest disseminated and adapted program in Tanzania. And it's with that reason we're coming together and with support from Thrive, whereby we regard Thrive as a large-scale multi-country research and policy program where Tanzania, Ghana, Sierra Leone, Bangladesh, and Kiribati also benefit from. And mainly the purpose of Thrive is to be able to build understanding on ECD policy and service delivery models that can be scaled up, but at the same time to be able to transform significantly, to significantly improve the early childhood landscape or outcomes in Tanzania and other countries as well. So with that being said, with this collaboration with Thrive, where it sticks to really bring the practical answers to different questions within the ECD landscape, we are able to see how, with support from Thrive and the research like this, is able to inform the implementation, and how TechDen also try to see to bring or to bridge the gap between the theory and the implementation of what's going on at the grassroots. So this partnership actually brings to life more informed interventions, informed decision-making, as TechDen continues to advocate for policy change and so forth. It's also informed with research such as this that Thrive conducts into that. So we are grateful for Thrive for a number of research and the body of knowledge that have been building in Tanzania to really inform the implementation. But again, with excellent effort done by TechDen in advocacy, mobilizing non-state actors to come on board to invest in ECD and building their capacity, we are able to start to see realization of different interventions that can be able to address such issues. With the government buying, I believe we can actually make strides in the field of ECD. And it's for that reason why these actors, they've come together with Ifakara Health Institute as well, and other partners, as you can see, to be able to actually put forth such studies. And we are here to share disseminate the learning. Hopefully, we're going to come up with very meaningful action points today to take forward. That being said, let us see what we have in the chat box. And I'll welcome Deo, Sia, Leona, if you have any questions you'd like to bring up for answering, please welcome.
Hi, Godwin. Can you hear me?
Hi. Yes, can hear you.
There have been a few questions in the Q&A. So one of them is, what measures have been taken to implement the strategic plans to bring about positive impact in the country, especially in primary level?
Thank you. Shall we tackle one by one, or Dr. Ester, would you like to take a few more questions before you start answering them?
I think we can go answer the first one, and then others can continue also brainstorming, because they might not have been having questions. Maybe due to the explicit nature of the presentation, maybe there are few, but we can also answer as we are going forward.
Okay. All right. Please, would you like to tackle that one first?
Yeah, I had the question that what measures has been done at the primary level, the lower level at the community, to address issues around nutrition. Is that the correct one, Godwin?
Yes, please go ahead.
Yeah, I think several measures
Yes.
has been taken, and you realize that Tanzania has services that are offered at the primary facility, like health facilities. We have like supplementation for pregnant mothers. We have routine monitoring of the growth for children under 5s. We have vitamin A supplementation, which is a national program. We have salt iodation as a national program. We have mass campaign for vitamin A twice yearly. And we also have food fortification that has been adopted as a global, as a country strategy to alleviate malnutrition. But the challenges with the food fortification is that it also reaches the people from the higher class because of the cost of the product, but also most of the local household are using their own produce from the farm and not buying from the market. And therefore, even when it's fortified, then they're not reached because they don't consume food from the market. They consume from what they produce. So that has been one of the limitations with the food fortification program. But you have other local partners who are supporting the fortification at the lower level. So we have also nutrition education being integrated within the services. But now we are also having the ECD services that are coming up embedded within the services. And that will bring maybe a little bit more robust approach. So we have several packages, but they just need to be strengthened. But we need to also address issues the cultural issues that are happening at the community. We have to address issues around women workload, especially in some places. We also have to address issues of male engagement into the parenting and caring. So all those things need to be addressed, but they are not reflected within our current policies and the guidelines. So those are just few things I've mentioned, but I believe there are even more than that. Bigger project has been carried in Tanzania under the support of many partners, but we also, so there are like big projects on nutrition, but they will say there are less of the direct big intervention from the government, but there has been a lot of effort from the other partners who are implementing nutrition in Tanzania. Yeah. So I hope I've answered your question, or maybe I've missed something.
Thank you. We definitely will hear a probing or follow-up questions, and then we'll see in the chat if there's a need for more clarification. But another question was, when child starts crawling, encounter stomach worms, which contribute to child stunting, does frequent deworming help to address this challenge?
Yeah, definitely deworming helps to address the issue of worm infestation. But we also need to advocate for a proper crawling, a clean crawling environment. You know, I've grown up in a village where mothers will always say, let the child play on the sand. Let them play on the dirty things, because that's where they build immunity. And I think that is something that we also need to really make sure that we are addressing, as we are also talking about the hygiene environment. So we normally we only promote hand washing behaviors and maybe use of improved latrines, but we have never had a good emphasis on the environmental hygiene and a proper clean crawling environment for children and also for the other children who are playing around. I've done a lot of observation in the household where you find a child is sitting on the floor from morning to evening. They have the wet clothes, they pick things from the floor and they eat, and they sometimes play even with the animal feces. So these are the things that when we are advocating for proper hygiene, we also have to integrate the hygiene behaviors within and outside the home environment. Yeah.
Thank you.
Yes.
Thank you so much, Dr. Esther. Another question was on the area of in line with what you just shared, the first and second question, what considerations that are there for children that are taken care in within the institutions, like orphanage and so forth?
Within the institutions.
Mm.
I think I have to admit that this is a very relevant question. And I would say that maybe just to add into the list, those are few groups that have been not covered well into our guideline and policies, include those who have disability, those who are in the detention centers, who are living with their mothers in the prisons and all that. Those children have not been very well covered in our guidelines. But what I could say is that for those who are advocating for nutrition in Tanzania, and even for the ECD in Tanzania, there is a need to make sure that our approach is inclusive enough to make sure that the children who are in the detention center, who are in the orphanage centers, who are in the prison center and all that, are also benefiting equally like other children who are at home. Yeah.
Well, another question that says, although Tanzania has done well in the last 30 years of stunting, what particular policy should be changed to be able to completely control stunting in Tanzania?
That question, I have to laugh because that question, as I mentioned earlier, stunting is not a one bullet thing. So if you look into the conceptual framework of malnutrition, what causes stunting? We always have layers. So you have layers. So the first layer, we say, what are the key causes? We say the diseases, inadequate intake. But when you come now, diseases and inadequate intake, what are the underlying factors? You find there is household food insecurity. You will find out the poor wash behaviors. You will find out the inadequate utilization of health services. If you look down into why all these food insecurity, when you look into the inadequate services and also the issues around the hygiene environment, what actually determine those factors is the basic factors, the poor socioeconomic status of poverty. There is issues around the government distribution of resources and the prioritization. There is issues around the culture and values. So these are like basic factors. So even if we look into the policy, there will be no single policy that will be a bullet to the stunting. Stunting requires multi-sectoral approach, meaning that if you talk into WASH is under a certain ministry. If you talk into issues around health, it's under Ministry X. If you talk issues around nutrition, it's also under a certain ministry. If you talk about issues related to fortification, you're talking of the Ministry of Industries and all that. So it needs all these key players together to come and just make sure that we are working together as a team to alleviate malnutrition, not as a single policy, not as a single player. All the policies need to be strengthened to make sure that they reflect the key issues that actually affect the child growth and development overall.
Thank you.
Yeah.
Well, a follow-up question is that since income is one of the influencing factor for child nutrition, which is relevant to ECD 2030 findings.
Yeah.
What is the best modality be applied to raise household income?
Hello?
I will say that, yes, somebody's saying something.
Yeah, thank you. It's quite an interesting question. And if you look at gender youth inclusion or gender women and youth empowerment, if you look at the framework, there are a couple of activities that if done as intervention widely, could they assist poor household in terms of gaining some income. There's activity has been done like in Linde and Mtwara, where women or poor family were identified and they were capacitated in terms of entrepreneur skills, also in terms of home farming or gardening, where they could just have a little entrepreneur activities to have some income. The other concern is if you look at during farming, post-farming, some people have no activity that they are doing after almost post-farming. And there could be issues linked to social economic activities that they could carry on while they're waiting for another season in order to participate in agriculture. Over to you, Dr. Esther.
Yeah, thank you. I think we also know that the government has so much initiatives to support women. So there are like these women who are advocated to coordinate among themselves, and they receive loans from the government, from the banks, and maybe a loan with a smaller interest from the banks. But we also have women, they organize themselves through the Vikoba, the village saving groups, and they also capacitate among them. So that also transformed to the economic empowerment. But we just want to emphasize that we also need to have a deliberate effort from the government supporting poor families. So we also have TASAF, you know, TASAF. TASAF also support poor families, but we definitely need to have more support that target children under 5s, and the amount that is allocated, if it's there, it's maybe need to improve a little bit more, especially for the poor families to be able to move outside from the stunting challenges. We have seen a lot of studies that have shown that when there is a cash transfer to the household, whether direct or indirectly, they can impact child growth and development. So we are seeing that is one of the key issues that government, if possible, they can look into it critically, continue supporting the poor families. And also women should be encouraged to participate in economic activities. Yeah.
Thank you, Dr. Esther. And I believe Generation Equality Forum and the plan also contribute to that a lot in Tanzania. Well, another interesting question is about investments. So one of the questions says there has been a lot of projects that have been implemented in those regions where malnutrition or stunting specifically is high, but the condition has been persisting. What can be done to scale up adoption and also pushing forward the agenda for implementation of the policy documents?
We had this question a long time ago, like what is happening with the regions. So I'll go back into one of the slides. There's a slide I was talking about some of the variations, especially the geographical variations. So I'll refer back to that slide and talk a little bit more about that. Yes. So when we are doing these interventions, I think there are things that as development partners, they need to look into it critically. So one thing that we have been doing maybe as a gap is looking into the conceptual framework of the causal pathway of malnutrition and adopting that as a key way to intervene. And the gap I've seen for a long time is most of these interventions are not addressing the core causes. Like if you look into a nutrition intervention that has been implemented for years in Tanzania, they are focusing more on nutrition education. But if you look into how much women knows about feeding their children, over 80% knows what they have to do with their children. They know whether they have to breastfeed, they know whether they have to do the complementary feeding. But what is missing is what we said in the qualitative study. So if you have all the knowledge, but you don't have time to prepare that food, you are overworked. You will never have a time to prepare a good quality food for the child. If you are doing everything in the household, like a mother is doing everything in the household with less support from the husband, then it's very unlikely that woman to have enough time to care for the children. If you look into issues around alcoholism, if the mother and the fathers, they're both drinking, what time are they doing the parenting role for their children? So that is also affecting. So most of the project, they're not going down into these factors like addressing the women workload, going down into addressing the male participation in the parenting, alcoholism, violence. So, and other things like wash behaviors, especially the places where children play and the crawling and all that. So you find that there is a missing link between what is invested and what is actually the main cause of the challenge. So it's until we go into the approach where we can help women economically, we can help them with the workload, we can help them with the distribution of work and the decision-making processes and all other issues that I've just mentioned, we can somehow, somewhere now witness the changes. So I would say that there has been so many interventions out there, but the approach has always been education, and also maybe promoting gardening and maybe keeping small animals. But when you talk of the gardening, you talk of keeping animals, it's workload. So this mother has to wash the dishes, has to take care of the children, has to cook, has to care for the husband, has to do the farming. When are they giving even time to feed their children? So you find a lot of children are left with their siblings, or they're left with their neighbors, or they're left alone at the household. So if you find a child, 4 years child or 5 years child is left with a 2 years child to feed. And for that reason, we are still having a big gap between what most of these projects are addressing and what is the core cause of the malnutrition and also child development overall in our context.
Thank you, Dr. Esther. Dr. Nkuba, before we proceed to the next question, Dr. Nkuba, I see your hand. Would you like to add to that? And please introduce yourself as well before you add to that. Thank you.
I'm Dr. Ester Nkuba from Tanzania Food and Nutrition Center. Adding to Dr. Ester Elisaria, and I think it is time now to decide to go deep to the, to the community. That means we have to use the human-centered design so that the female and male, they have to own the intervention so that they can be part of the program. I think this one can help also. Therefore, the implementing part, the implementing, the partners, the development partners, they have to look on that also, and everyone who is responsible for that, so that we can have the solution from the community, not from us. Thank you.
Thank you so much, Dr. Nkuba. Yes, totally agree with you. I think it's through the highlights of such studies like these ones that TechDen and Thrive team and HiChat try to put together with the support from the government, that we are able to see or get some ideas of the kind of interventions we should be investing in more to address these issues. In another interesting question, I think it has two parts. One of which you already touched on, issues of how economic situation or income level affects issues of stunting. But the second part of the question, which is also interesting, is the availability of healthcare services. And how does that contribute to stunting or malnutrition? Either you, Dr. Nkuba, Dr. Esther, you want to go first, Dr. Esther, and then Dr. Nkuba maybe can also add something to that.
Yeah, thank you so much, Godwin, and whoever asked me that critical question. We know that health services is the first contact place for the pregnant mothers. So what I can say from this point is that stunting is not happening when the child has been born. It starts from in utero, when the child is into the mother's womb. So meaning that whatever intervention the mother is gaining from the facility, like let's say the mother, when they visit a health facility, they are counseled on nutrition. They are taught about preventing illnesses, sleeping under the bed nets. They are taught about the healthy eating behaviors. They are also given supplements. They are also given anti-malarial drugs. What does this mean to this woman? It means that when the mother's health and nutrition status is improved, this mother is likely to give birth to a child who is healthy, a child who weighs above 2.5 kilograms. As I've mentioned earlier, is that children who are born with low birth weight, they are more likely to grow as stunted children if they are not given enough care. So for that reason, the care for the mother starts, actually it should start even before you conceive. It should start when you are thinking of conceiving. You have to make sure that your health is good. So a lot of women goes into the pregnancy when they have malaria, they have worms, they have they have everything. So they are sick. So when you go into the pregnancy, when you are you have nutrition deficiencies, when you have micronutrient deficiencies, when you have also poor nutrition, poor feeding intake, automatically you are giving yourself a ticket that your child is not going to be born as a healthy child. So when you have to a health child, this child is likely to grow into a good child. But also at the health facility, the mothers are given advice on how to breastfeed, For 6 months, their children, they are given advice on how to provide appropriate complementary feeding. They are also given other health-related education. So we'll find out that if the primary facility is properly used, it can be a very good point where we can see or witness more improvement. But I will say that this is not enough, or it's not only enough for stunting overall. Stunting, as I've said, it needs more than just the health facility. It needs changes in the behaviors and many other things. So you might get the education, but you're not practicing. So you have the option to practice. So all these things need to go hand in hand. While we are getting the information from the facility, also the community has to get the proper information and the changes of behaviors over time, which can also translate to the better outcomes. And other members can also contribute, my Esther and other colleagues.
All right, thank you so much. Do we have any more any other take on that? Dr. Nkuba, yes, karibu.
Yes, she explained it well, and I think another thing to add, we think we have to make sure that we invest in the early childhood so that we can have all them in board. We know that at this time, it's the second window of opportunity for growth and development. That means we have to make sure that this critical time has to be taken into account to make sure that their eating habit has to be changed through their lifetime. Thank you.
Thank you, Dr. Nkuba. I think you both highlighted something very critical. It's not just issues of health, but then again, there is the issue of early childhood development, and we agree on that. And I think that touches one of the interesting highlight, or just a confirmation that is needed, that when you talk about stunting, that includes even the first 1,000 days. Is that correct, Dr. Esther?
Sure, you are right.
Yeah, you're very right.
Yeah, so another interesting question that came about, and I think you started talking about a little bit, Dr. Esther, is about the social. I think this is where another challenge comes in, as they say that did the research address the issue of social norms as an influential factor in nutrition, particularly in the context of relationship between production and consumption at the family or society level? Was it part of the research as well?
No, we didn't go deep into the norms and the culture and values, but we have to admit that they have a big role to play. So that's why I said, even when I looked into the determinants I was talking about, you remember I mentioned about the issues around the alcoholism and domestic violence and other behaviors and the feeding behavior, because we have witnessed from other studies. We did a study in Mbeya, but also in 5 regions of Tanzania. And we realized that actually there are a lot of food restrictions when the mother is pregnant or they are breastfeeding. And one of the things they were talking about, things like mother not discouraged to eat eggs because they are worried that the child will be born with a bald head. Yeah, they have no hair. And they will also be stubborn. So there are so many myths around food, and that also limit the opportunity for these women to feed properly. But there are also so many other things, like we also realize, like in places like in Njombe, where when the mother gives birth, the father moves outside the household because they feel like that's not the time when they have to be in contact with that woman. And by doing so, meaning that they are leaving all the responsibility of caring to a woman. And for that reason, this woman who have just given birth is also left with the other young children to take care. And that happens that now the mother has no time to care for the newborn, but also for the other children, because she's still weak to even handle some household chores. And for that reason, you find that when you talk of the male engagement, is actually cultural inbuilt. The culture tells men not to work. It's not their responsibility to care for the children. So if you have, they know that their job is just go find the money, come bring the food at home, and that's it. So that change to just know that the man has to be part of the parenting. It's a norm, it's change of the culture and the values. And that needs time, but also need to, as a country, we as a leader, we also have to invest on that as part of change. But you talked about the food system. So I wanted you to repeat again about food system and the relationship between the norms. There's something you mentioned about food systems. I think someone saying, how can food systems and nutrition policies be strengthened and to translate to local food abundance or something like that? So definitely food system is very necessary, and we need investment on that. But something that actually limits the whole thing of the food system is the climatic change. We are now, most of our farming and everything in the food production is more reliant, it's a rain-fed agriculture, and less into the more advanced agricultural technologies. And that also limits the production and also increases the vulnerability of the household. So there is also a need to invest on the food systems, making sure that we minimize the losses before harvesting and after harvesting, proper handling and all that. So all these things need to be strengthened as part of the implementation on improvement, because when you improve food systems, you are improving household food security. So when you improve household food security, meaning the feeding in the household and the quality of feeding will improve. So there is a very close link of the food systems and the nutrition, and that is one of the key things that also need to be addressed.
Maybe adding to that.
Yeah.
Yes, we know that the food system also comprises the policies, services, and the actors needed to ensure the population that they have access to nutritious food which are safe and affordable. And also we have to take on account on the advertisement on the food. There are advertisements which are not good. They are just taking out our children, especially the adolescents, going to consumption of the junk food. Thank you.
Thank you so much, Dr. Nkuba. I mean, in line with the policy, speaking of the policy, there is a question here concerning MNAP1, that reading the phased out MNAP1 in Tanzania, it mentions the food and nutrition policy of 2016. Was this something in the making that did not come to exist? Or is it still in the making during the plan implementation? Would you like to say
I'll leave that to Dr. Ester Nkuba. I'll leave that to Dr. Ester Nkuba.
Can you
the question
can you come again the question?
Yeah, as we're talking about the policy here, the question says, reading the phased out MNAP1. So they're talking about MNAP1, and it mentions the food and nutrition policy of 2016. The question is, was this something in the making that did not come to exist, or is this still in the making during the plan implementation? So I think my understanding is that I want to see if the policy is actually in effect, or in the MNAP2. Is MNAP2 up and running right now, or still in the making?
Okay, the MNAP,
Dr. Nkuba?
The MNAP is still working. We are about to go for another. Can you hear me?
Yes, we can hear.
Can you hear you? Yeah.
Yes. Then the MNAP is still working. We are still working with the current MNAP2, which is ending with 2026, and now it is under midterm. And regarding the policy, we know that we are still using the 92 policy, and we know that it has the shortcoming. It comes with the policy failure to address overweight and obesity and the other things and the new things which are coming. And Dr. Esther has explained it well during her presentation that it needed to be reviewed so that it can account on the emerging issue at this era. Thank you.
Thank you so much.
Just to add a little bit, I understand that there was a time when the review process started, and somewhere the review stopped. So I don't know what happened, but I understand that there was a time when we were working to develop a new nutrition policy, but it's somewhere it went on 2016 and stopped. But now I think we have revitalized the effort, and I think I've had a lot of meetings ongoing to revise the current nutrition policy. So something maybe good might happen between now maybe and next year.
Thank you. So what's also interesting they're talking about here is the strategies. As you're talking right now on the plans and policies, another question that is in line with that is, how can we make sure that the strategies are inclusive and consider children with disability, they are culturally sensitive, especially within the diverse communities like the ones we have in Tanzania. So how is the component of inclusivity and the needs of the children with special needs of children with disability are being taken into account in the MNAP and other strategies that are supposed to address issues of malnutrition and stunting in Tanzania?
To be honest, I've reviewed the MNAP, I've reviewed the MNAP 1 and 2. There is less and less coverage of the children with a disability and those in the orphanage or detention center or prisons. So I believe that as we are moving forward for the MNAP 3, but also with the new policy, I think this is the area which we really highlighted when we were asked to provide feedback. I was part of the people who were asked to provide feedback on the policy development. And I think one thing that I brought forth was the need to holistically address the need of the children who are normal, but also who have disability or who are in the vulnerable environment. So we hope that maybe the upcoming policy and the MNAP will have a specific section or objective to address those in the vulnerable environment. Maybe Esther can also add, because she's maybe leading this assignment. She can say something. I think it's under the Ministry of Health, but also TFNC, they are very well engaged into that.
Dr. Nkuba, would you like to say something about it?
About the ENAP?
About inclusion of children who are vulnerable, like those with disabilities or with who are in the prisons or have special needs.
And also consider cultural sensitivity with the diverse communities we have in Tanzania, if there is a consideration of cultural diversity.
Yeah, as she said that, I mean, the policy now is under review. It is under the Ministry of Health. TFNC are the only a secretariat, but things like these, they have been taken into account, and we are waiting for the updated one, so that it can, I mean, this one covers all the things which we are missing in the last one, including the disabilities and all kind of issues which are missing in the last one. I mean, the current one, which is just the outdated one.
Thank you so much. And one thing that I understand is that in Tanzania, the reason why we also have this series of webinars, and more like this will be coming out, is also part of us trying to see the alignment with this and childcare. And Dr. Esther, you've mentioned several times, as we understand, childcare is the kind of care that a child in Tanzania, for example, you're looking for children under 3, the kind of care they receive when they're not with their parents. And we understand as we continue to, with the women empowerment and women engaging more and more in the field of work, and you still have the young ones, and they have to be taken care of. There's been 2 options. One of them is to live with them at home with a housemaid, and another, we have several options, but these 2 are also prevalent, but also another option is to take them to a daycare. And we have 2 questions that are, linked with the situation with the childcare. And the asking question is, some children spend more time with the housemaids. To what extent does this situation contribute to stunting and malnutrition?
I'm laughing because this has been it's affecting all of us, not only the one who is asking the question, but especially for the employed mothers. We are struggling. We are working hard for others, but maybe not for our own children. And I would say that lack of parenting overall really affects child development, not only the nutrition, but the overall development of a child. We always know that we leave maybe in the morning, we leave food and everything at home, but we don't have a mechanism to control what the child has been eating from morning to evening. So the only thing that can tell us whether they are eating properly or not is when you go into the facility and you are seeing there is an improvement in terms of their growth and more of the growth and not even the development part. But I would definitely say that for we mothers, leaving your children a lot with the housemaid, they become very much disadvantaged in terms of their connecting, their bonding with you, but also there are things that we learn from our mothers and our parents. And spending much time at work is important, but you always have to find time for our children. When you come back home, we should not leave everything for the housemaid, but making sure that we are also engaged into the caring, into the washing them, feeding them, and doing other things. And that will help us at least engage, not necessarily 100%, but maybe somehow. The data from Tanzania, we don't have the data on the housemaid and how they care for the children, but that will be an interesting area to explore, like the children with the employed mothers and non-employed mothers, to see how they're faring in terms of that could tell us a little bit. Though it's kind of contradicting because we are seeing people with the high economic status, their children are growing normal. And those who are high in socioeconomic status, they are also the ones who are spending less time probably with their children. So this kind of a contradictory scenario, but we'll have to look into it holistical, not only into seeing a weight increase or gain, but in terms of overall the development of a child. There is a benefit to have a parent engaged into the parenting activity.
Thank you so much, Dr. Esther. And I think I just wanted to, in line with that same question, if you can also, you maybe Dr. Nkuba as well, come to another area, the other option for for children to receive care, which is also the daycare centers. And one of the questions that came out is that how can we ensure that the food provided in the early childhood education center in Tanzania impact child's health and cognitive development? How is that done? How can we ensure that? Dr. Nkuba, would you like to go first on this one?
Yeah, she can.
Yes, I'm just start here.
So
You know,
yes.
in the child care centers, and I think we have to think about, because it is very difficult to go and you can, but based on what? We must have the regulations which can guide them how to feed their children or how to take care of their, the children where they're in the care centers. It's difficult because they're having it's an institution. Therefore, there must be something to guide them. Maybe Dr. Esther, can you come in for that?
Yeah, thank you so much, Godwin, and whoever asked you that critical question. I had time to review the daycare center guidelines and to look into the nutrition aspect. One thing that came as a big limitation is that these guidelines stipulate that a child should receive at least porridge. That is what is said in the guideline, at least porridge. And if you look into the views, because we had time when we had to ask mothers, like whether they're using these daycare centers and whether they are willing to use them. And one thing that came clearly is cost. So when you increase the number of meals and the variation, the varieties, it also reflects into the cost of that service. So many families, they are battling to afford the service, and that's why a lot of them, they're also not opting not to use the facilities. So it is, I don't know how to say it. It's a situation where I find like it's necessary to promote a balanced meal and a healthy meal at the facility, but at the same time, it imposes an additional cost into the running cost, and that is where a lot of mothers, they feel they cannot be able to afford. There are some facilities where they have promoted the mothers to bring the food themselves and they cook at the facility. And that has been seen as one of the strengths, because if a mother X brings food X, another one brings B, another one brings C, at the end of the day, when they cook, they have the varieties. But I remember when I did some of the questions around the daycare centers and the use of daycare centers and whether the mother should bring the foods into the daycare centers. One, I remember some of the ladies, especially in the area of Njombe, they said to us, some of these families, they are witch, and if they bring their food, we don't trust whether their food is okay. So you find there is a lot of also, while this can be important, but also there is also a setback. So I have a feeling that daycare center could be a very good place to help us promote good nutrition, definitely, and also to monitor child in terms of health and development. But they're also running some shortfalls because when you look into the stunting graph that I've shown you, the stunting happens in the first 2 years of life. So you find the stunting goes, if you look into I will show you the graph again. If you look into this graph, you find that stunting starts from 6 months to when the child is nearly 24 months, so 2 years. And in most cases, at this period of time, children are not taken to the daycare centers. They are taken when they are 2 years and above. And for that reason, the stunting has already happened. So the best way to intervene in stunting is from pregnancy and from the time when the child is in the first 2 years of life. At the daycare center, yes, we can improve, but once they are stunted, it's very hard to reverse stunting after 2 years. So they can be reversed a little bit, but not 100%. Some studies, they have shown that they might improve in the later stage, but it does not affect their brain size or brain mass. So they can increase in terms of the height, but with a smaller brain and also smaller brain mass. So that's why we are talking about the health facility as a first entry point to rescue their 1,000 days. But if we are going to the daycare center, definitely good nutrition is needed for the child to continue growing for the other 1,000 days. Yeah.
Thank you so much, Dr. Esther. With that being said, I think I'll definitely pause there for the questions to respect the time. And we're almost out of time, a few minutes are left. And I would like to welcome, first of all, I thank you all as panelists. Really, you have provided such an insightful, the presentation was amazing, and insights were very much helpful. I'd like to welcome Dale now to say something before we wind up our session. Dale, please, karibu.
Yes.
Oh, wow.
Hi, everyone. Can you hear me?
Hi.
Yes.
Yes. Thanks. Thanks, Esther and Esther, for being on top of this, and Godwin, thanks a lot for your sharing. I think this is a very good discussion, and yeah, I think it was very much successful because of very high engagement from participants. And just so you know, this is the first webinar from a series of webinars that we'll be doing. So having such high number of attendance, that was very brilliant. So I have three things to talk quickly. One, we'd like to hear from you in terms of the feedback regarding this session. So we have shared the link on the chat, but also you can scan at the end of the presentation. If you can go at the last slide, you can scan and they provide us feedback. Yes, the last one. Because this is the first webinar, we'd like to find a way to improve these webinars more as we go along. And we are intending to have these webinars even after Thrive, after after this program ends. So it will be good to hear from you in terms of the feedback. Second, we'll be sharing materials, the presentations, slides, reports, policy brief regarding this projects. But of course, I've seen my colleagues from communication team, they have already shared the link on the chat regarding where you can find the policy brief for this particular project. But I promise you, as I send an email to all of you to share the materials. The last one, which is the most interesting one, we are planning to have these sessions at least quarterly, and we are inviting some other presenters. It's not just about Thrive. So that's why we are in collaboration with TechDen, but also the Ministry of Community Development to ensure that we have presenters from number of ECD research. And yeah, we have to be honest that we would prefer to have the presentation mostly from Tanzanians, those who have higher priorities, but of course, we are not also limited to Tanzania only, though we prefer, at least for this first year, to have some presentation from Tanzanian-based research. And yeah, if you have presentation, please get in touch with Godwin. I think you can provide the email address, you can copy me. But as I said, we like this forum to proceed even after Thrive program. So that's why we want the government and take them to take a lead in terms of hosting these presentations. Of course, we'll be available to support with our communication team, with Thrive some technical expertise, but in terms of the ownership, we'd like the government take them, and of course some other counterparts who are based in Tanzania to take a lead in terms of coordinating and sharing the next presentation. So yes, the plan is to have at least once after 3 months, one presentation after 3 months. However, if we have a high volume of presentation coming up, we are more flexible to have at least one presentation per month. So, but at the moment, the plan is to at least to have one quarterly. So yeah, so with those few words, I would like to thank you again, Esther and Godwin and all the participants. And apologize, you may have seen the couple of Delgados in the list, because those who received the link that for myself, when they joined, they appeared as Delgados, but I just joined once. There are a couple of other people who joined. Yeah. So thank you so much, and yeah, looking forward
Thank you to Dale.
Thank you, Dale. And before we wind up, I'd like to welcome Director from Tanzania, the Executive Director of Tanzania Early Childhood Development Network, to say something. In the meantime, please remember there are links to more information in the chat. Please remember to rate our session today so we can continually to improve as part of our child care campaign initiative. And if our other partners, as Dale said, we wish to also to get our support to organize a session like this, you have something, please feel free. And Director Mwajuma, please, welcome.
Good evening, everyone, and thank you for Thrive to organize this webinar. It's our first webinar ever being organized by us together with partner, and we would like to invite everyone in Tanzania to reach out to TechDen, as all of you have said already. We'll be happy to host and support your webinar to be held. Otherwise, thank you for the presenters. I think we have a lot to share, Dr. Esther, from the research that you have done and a Thrive project. And we wish all the best for the one who wish to uptake the recommendations. Whoever is willing to learn more, they are welcome. They will be supported to be given area of interest, maybe regarding the findings that the researchers, various apart from this one and the rest, so that you can invest in terms of planning your program to be implemented in those areas. So otherwise, I see a lot of members from TechDen. I see Money Girls. I see a lot from various places. Thank you for participating. One thing for everyone to take, I think we are also undertaking child care campaign, and this can be part of the campaign. Just take your action wherever you are. We promote development of community daycare centers where we think it can be a cure for stunting problem. Thank you very much and have a lovely evening. Thank you.
Thank you so much, Dr. Mwajuma. And yes, there's a challenge ahead of us, as Dr. Mwajuma said, and there is the issue of inclusivity, where our presenters have highlighted that needs immediate intervention and immediate action, and there's still not much has been done about it. So partners in this webinar take that as an opportunity, and TechDen is more than happy, and Thrive team to be able to work with you if you have any ideas and to be able to be part of that policy advocacy to ensure that there's inclusion of children with disability and special needs in our policies and strategies. Please remember to get more information from our social media pages. There are links on the chat for Thrive and Tanzania ECD Network. Just go online and visit our websites for more information and materials and so forth. Thank you all. And I wish you a lovely evening and see you again soon. You will see our advert again for the next webinar, and stay tuned. Thank you so much.
Thank you so much. Thank you so much all.